Actually, Plata. Thank you very much, dear Chairman. Those are my disclosures. So overweight and obesity are independent risk factors for stress urinary incontinence. There is a strong association between SUI and obesity that risks the effectiveness of any anti-incontinence procedure we perform. Data for cure rates of tension-free vaginal tape in obese women are contradictory, and there is important clinical heterogeneity. So the goal of this study is to perform a systematic review and meta-analysis of the literature to evaluate the subjective and objective cure rates in obese women. This is the PICO question we have. This is the Prospero ID we have for this trial. This is the literature search we conducted. We include those terms. We searched Central, Ovid, Medner, Embase, Scopus, Web of Science, PubMed databases. Those were our inclusion criteria as well. And this is the patient stratification in 30 kilograms per square meter as obese women and non-obese less than that. Subjective and objective cure rate evaluation, and those were the PRISMA evaluation we conducted. We started with 286 records, but we ended for the qualitative analysis with 12 records, and then for the quantitative analysis with 3 records that were excluded because of all those reasons you find in the right side of this slide. The studies with the qualitative analysis were read in full, and hand search of these articles were also performed in order to get more information for this trial. We determined quality assessment using the review manager and also the grade classification. As you can see in green bars, there is a low risk of bias in the trials we find, but the other ones were excluded because of high risk of bias. We decided to perform a meta-analysis on the Codomos data, cure versus failure, under the random effects model for the subjective and objective evaluation using the I-squared and the chi-squared test. And we also use the risk ratio evaluation for the point estimate. And this is what we found in the forest plot. This is objective evaluation, the subjective evaluation, and the overall assessment. And as you can see here, the I-squared were very low, which means that the heterogeneity the statistical heterogeneity for both either objective or subjective were really low. And what we found is that the point estimate was around 1.65, which means that there is a chance of 65% more failure that disfavor obese women who underwent or who undergoes to one of the surgical procedures, in that case, the slings. This is the publication bias with the funnel plot. As you can see, most of the trials were really close together. We tried to find more trials, but there were no information in gray literature that can be available, but the publication bias can be ruled out with this. So the few studies to run as a group analysis and a meta-regression as well, no information to meta-analyze complications in obese and non-obese women. And most of the studies covering the topic of obesity and SUI are retrospective. Most of them are cohort studies, and the findings are heterogeneous. Our meta-analysis focus only on randomized controlled trials and show a subjective and objective evaluation that disfavored obese patients who underwent a mid-urethral sling. Other meta-analyses have shown no difference, and the reason is because they are including several different kinds of trials, cohort studies, retrospective analysis, and the risk of bias is completely different. So we can conclude in this meta-analysis that obesity is a risk factor for a poor outcome after tension-free mid-urethral sling. Being obese and undergoing a mid-urethral sling procedure increases the risk of failure in 65%, but we need more clinical trials in order to conduct subgroup analysis, and this is one of the limitations of this trial. We don't know which type of tape, for example, are responsible for this. We didn't take into account the follow-up length, the other comorbidities the patient can have, and the complication rate. Thank you very much.
Any question? Did you evaluate the difference in terms of sling, retropubic versus TOT?
Yeah, the problem is that there is not enough information. There are only 3 randomized controlled trials, so it's so difficult to make a subgroup analysis on that. One of the things we plan to do in advance is to check if TBT retropubic is better than the TOT. There is only one trial that addressed that question as a randomized control trial, but we were not able to meta-analyze this information because you cannot do it with just one study. You need at least 10 to do that.
Okay. Any other? Okay, please.
Maria Ström, Oslo. I just wonder the 65% increase, what does that mean? Because what was the general mistakes they did during the surgery? So how many failures what was the mean failure rate?
Well, actually, this is a number where you put the proportion of patients who are better and the proportion of patients who fail the procedure to get a relative risk. So there is an increased risk of failure if you are obese when you compare with non-obese patients. That's what it means, actually. It's just a number.
Yeah.
It sounds big, 65% relative reduction. Actually, it is the complement of the relative reduction. It's
So-
too high. Seems to be high.
Yeah, and
I think.
I suppose it's not.
Yeah, what will be interesting is to translate this into the number needed to treat. How many
Yes.
patients do I need to treat in order to have a
Yes,
failure?
that's what I
We didn't
aiming
address
for.
that, but it's
No.
very simple to do. It's just to do the math. I mean, 1 over the relative risk reduction, and you have that number, that magic number.
Okay, thank you.
Thank you very much.
Thank you.